Right. Wait a second. Let's give it one more minute and we'll get going. All right, I guess this is a brief one today. Okay, so this is a pacemaker tracing that came from an interrogation of a Boston Scientific device. And the question I'm asking is, so what we're looking at is lead 1, which is not attached to the patient. So patient wasn't hooked up to ECG during the time of this interrogation. The middle one is the atrial electrogram, and the bottom one is the ventricular electrogram. So, Tarek, why do you think it is that the atrial electrogram looks the way it does?
See.
Well, what's unusual about it?
It's like what I see the recording of the atrial contraction, but then it's followed also with the ventricular recording too. It's matching it.
Mm-hmm. That's astute. I agree with that statement.
And then it seems to have I see also like between the atrial and the ventricular recording, there is like maybe an extra beat.
You're referring to this this signal
Yes.
here?
Yeah.
Yeah, I mean, what this is actually this is a transvenous system, and what we're looking at is actually the electrogram of the atrium, but also, as you said, this is a far field ventricular electrogram. Is there any where do we normally place transvenous leads in patients when we're putting an atrial transvenous lead in? What chamber or what part of the atrium is the usual target to put this lead?
In the right atrium.
True, but where is there a particular location in the right atrium that we normally will put the lead? That's true. It is the right atrium.
Like in the high right atrium.
Yeah, we do usually try to put it up high in the right atrium, but a particular location high in the right atrium. Let's see, I'll cross over to Maya. Maya, any thoughts on location in the atrium where we would put the lead, which is the standard, at least the first best choice usually?
So I'm not entirely sure, but is it kind of near, we said high right atrium, is it near like the SVC RA junction?
It is, but I'll just answer the question. It's the right atrial appendage. That's usually the most common location that we sort of shoot for, is the RA appendage. And the reason we do that is we think it's a more stable location for the lead to go. And as you know, that is kind of high in the right atrium. So Maya, any thoughts on why it is that we might be seeing this very large signal that seems to be right on time with the ventricular electrogram. Tara correctly noted that it appeared as if there was a signal there. Well, Dave Barris is asking if we're having a conference today. Hold on. I think because I changed the conference schedule here, or the meeting room today, because I think that the prior conference timed out actually. Hold on, I'm just going to send it to him. Sorry. So the electrogram, any reason that you could think of why in the right atrial appendage, Maya, we might be recording the ventricle?
Well, trying to think like anatomically, I guess if it is overlying the ventricle or it's like in close proximity to it, we might get picking up some of the signal, but
That's exactly right, actually. The right atrial appendage hangs over part of the right ventricle. If it's large enough, it can be actually over the outflow tract of the right ventricle. So yeah, so that electrogram, it's not uncommon if you're deep in the right atrial appendage, and if the appendage is a longish appendage, that you will have a pretty big far field, we'll call a far field ventricular electrogram. So that's what we're seeing here. It's actually not uncommon to see some far field ventricular electrogram. What's unusual in this tracing is that the ventricular electrogram is nearly the same size as the atrial electrogram, which is, to just give you some insight into how deep into the appendage this lead likely was, and also how large this appendage was and how it hangs over the right ventricle. So just an interesting observation that we see somewhat regularly when we put in catheters there. And actually, when we're in the EP lab, as you guys know, usually the goal for the atrial catheter is to put it in the right atrial appendage. And so the next time you're in the lab, look at the right atrial appendage, which in our lab we usually notate in red, the atrial electrogram. And you'll notice oftentimes that there is a ventricular electrogram on it when we're in the right atrial appendage and hanging over the ventricle. So, okay. So this is a ZO recording of a heart rate trend from an adult congenital patient on a Holter or a ZO that I reviewed a couple of weeks ago. This is a Fontan patient. And I'm wondering if you could tell me something about this rhythm. So, when I read a ZO, of course, I'm interpreting the actual ECG tracings, but I'm also not only interpreting the ECG tracings, but I'm trying to make comments about the heart rate trends in general. So let me ask Dr. Bebbia, who just joined us from the other room. I'm sorry, guys. Unfortunately, I think that other room expired because that meeting was going for many years now, I think 2 or 3 years. And I don't know why, but it came off the calendar. So I had to create a new one. So I apologize for that. So Sergey, if you were describing this, you're reading the Holter, something that we often have to do as a cardiologist. In this division, I read them also where, have an electrophysiologist read it, but it's not uncommon that a general cardiologist will read their own Holters or ZOs. So how would you describe this heart rate trend, and does it suggest anything to you? This is an adult congenital Fontan patient.
Good morning.
Good morning.
Sorry for the delay.
No worries.
Well, so we're looking at the heart rate trend, right? And we see that the dark, like the black dots that I see, and then the this range above and below the black dots. Is that
Yes.
the heart rate kind of range?
Yes.
Between which?
Yeah. I think this is like, I don't know, maybe every minute or 2 minutes, or each one of those
see.
dots. Yeah.
Right. So we see that the overall, most of the time the patient stays at a heart rate at about 75 or so. And then we see episodes that are pretty frequent when the heart rate goes up to 100 and even more than 100 a few times, but mostly, I guess, up to 100. And then the way it starts, it's actually interesting because sometimes I see that there's a gradual, warming up and cooling off, but then in the other episodes, it seems to be more of an acute start.
Well, it definitely, would you agree? It looks like during the hours we would assume are awake,
Sure.
that the heart rates are a little higher, right? On average, not a lot higher, right? But right. So you're saying that we start here and maybe the heart rate's more in the, I don't know, let's say low
80s probably.
Then we go to sleep and it's pretty much lock at about 75. And then patient wakes up, there's some activity. And, so how would you describe this? What do you think is going on? Is there anything non-physiologic about this? I mean, basically, the patient almost never has a heart rate that exceeds 100. Do you agree with that? I mean, there's like these two little spots here, which may even be, I don't know, they could even be a mistake, but let's assume they're real. But essentially, the patient lives between 75 and 100 beats per minute, almost exclusively.
That's kind of strange. I mean, that's slow.
So what do we know about Fontan patients that could explain that? And
well, he can be in a heart block or.
Okay, so if he was in heart block, let's say he is in heart block. First of all, how common is heart block in Fontan patients?
Well, since you're asking, I assume it's not very frequent.
Well, I mean, it isn't because, I mean, it's nothing, I haven't actually ever thought of this before, but the reality is it's very unusual to see a Fontan patient in heart block. It's not unheard of. It certainly happens, right? Because we have patients with L transposition who have single ventricles. And what's the risk of spontaneous heart block in someone who has L transposition, Sergey?
In L transposition. Higher, I guess.
Yes, it's a fair bit higher. It's about 1% per year cumulative risk. So an easy way to think of it is by the time somebody has reached the end of their life, there's about a 50% chance that a patient will develop heart block if you have L transposition. So that would be one category of single ventricle that would have pacemakers. But the point I'm trying to make is when you do a Fontan, of course, there's not usually a lot of intracardiac work being done other than on the atrium. And so actually, it's unusual to see a Fontan patient with heart block. It's not unheard of, but it is somewhat unusual in comparison to more complicated intracardiac repairs like people who get complex double outlet right ventricle repairs, or even AV canal repairs can sometimes get heart block, or even simple VSDs can get heart block. So, okay, so
I guess the simplest explanation would be some kind of sinus node dysfunction.
Right. So Fontan patients are one of our most common sinus node dysfunction patients. What percentage of ACHD Fontan patients get sinus node dysfunction, Molly Marshall? What do you think? Like if we went into Dr. Ali Zaidi's clinic, and if he had 10 Fontan patients who were 30 years or older in the office, which would be quite remarkable, what would we think? What percentage of them do you think would have sinus node dysfunction?
I'm not sure, but I would toss a guess out of 10, maybe 3 or 4 of them.
Actually, it'd be much higher than that.
Oh, wow.
Like 80% or more have sinus node dysfunction. Fontan patients very commonly have sinus node dysfunction. And in fact, the longer you follow these patients, the more common they develop sinus node dysfunction. And this is because, of course, they've had a lot of surgery around their sinus node. Now, it used to be, I think, even more common in the era when patients had lateral tunnel fontans, because there was a lot more suturing around the area of the sinus node. In the era of the external conduit, it will be interesting to see if we see as much of a degree of sinus node dysfunction as we have traditionally with lateral tunnels, or even with more old style fontans where there was still a lot of suturing around the sinus node. But it is an interesting question that someone probably should study at this point, because there are enough extracardiac fontans who are probably in their 20s now that we could probably start accumulating or accruing some data in this regard. So why do you think it is, though? So let's get back to Sergey. So Sergey, if you're describing this heart rate trend, some of you may get, you've all probably gotten Holter or Zio reports from me occasionally. And sometimes when I'm in a judicious mood or have a little extra time, I will comment on the heart rate variability. What would you say about this? Is this a normal heart rate variability? Is this abnormal? How would you characterize this?
Well, we've already mentioned that the heart rate range is not that normal, right? Because it doesn't go above 100.
Right. So sometimes we would refer to that as sort of a blunted heart rate range or response. What do you make about this? Is it odd to you that the heart rate never seems to go below 75?
Yeah, that does look strange.
Any theories on why that might be?
Well, maybe because it's not sinus rhythm. Maybe it's an escape junctional rhythm, for example, or
okay.
Accelerated.
It could be a junctional rhythm, but are junctional rhythms are they that regular? I mean, you could almost take a ruler, right, on this heart rate line and draw it right across.
Much more common.
That's the most reliable junctional rhythm of all time.
Yeah, much more common explanation would be a pacemaker, probably.
That's right. So that honestly was the most important reason I wanted to show this, is that when you see a heart rate trend and you see that there is this baseline that is almost like, literally looks like you could draw a ruler across it, that's because we can tell from this what the lower rate limit of the pacemaker is, which in this case is 75. An interesting observation also is, this is an adult patient, presumably is active, and probably has the feature of rate responsive on. So as we all know, pacemakers typically have some kind of a sensor, the most common being a piezoelectric crystal that can detect motion, and and then the device is programmed to slowly raise the heart rate from the lower rate limit when it detects motion to try and simulate what happens with sinus, as the sinus node increases, typically with sinus acceleration with activity. But you notice that the heart rate range is still very limited, right? We're barely getting to 100. Now, the interesting thing about this, and Josie and I have discussed this in the past, is that if you can actually, so the first thing to say is most pacemaker sensors are very insensitive. That's the sort of out of the box setting, which is that they don't really sense a lot of activity and they don't change very much with movement. And the other thing is that if the device is in the abdomen, it tends to not detect motion as well as when it's in the shoulder. But you can make these devices more sensitive. But in my experience, most patients hate that feeling, even though the degree of change in the atrial paced rate will be very similar to that of or even less than that of a sinus node. Most patients who are used to being paced within a certain heart rate range become very, very uncomfortable if you make it even a little more sensitive. We had a very interesting example of this just a couple of months ago. One of my patients who had an epicardial pacemaker defibrillator, which had been in place for essentially since he was 3 years old up until his mid-20s. Finally, one of his external patches broke, and so we upgraded him to a transvenous standard dual chamber pacemaker defibrillator. And every time he got in his car and was driving, he felt his heart racing, and it was driving him absolutely crazy. And even though the settings that we put on his pacemaker were exactly the same as his prior epicardial system, and what basically we discovered was that the small amount of rate responsiveness, which had always been on his device, when it was in his shoulder, it was so much more sensitive that with the jostling of the car, hitting potholes and things like that, his heart rate was going up to about 80 to 90 beats per minute from the lower rate limit, which was like 60. And he was very, very uncomfortable. So we had to basically turn that off. And as soon as we turned it off, he immediately felt better. So one has to be careful with this. And this is also, by the way, one of the reasons why when I meet a new pacemaker patient, particularly one who has had care by a different physician for a very long time, I will almost never make a change in the pacemaker settings, except maybe with the output of the pacemaker if I feel the threshold is changed or doesn't appear, the setting is inappropriate. But I will almost never change the heart rate on a pacemaker in a first encounter, because you can create distrust for a patient because of how badly they feel when they leave your office from a change. So if I were describing this, what I would say is that this is a pattern of limited heart rate variability or blunted heart rate variability with a fixed lower rate suggestive of an electronic pacemaker with a low rate limit of 75. That's how I would describe that. Okay, any questions about that, Tracy? All right, I think we've beaten it to death. All right, so this is a complex heterotaxy patient who had a stage 1 palliation for single ventricle disease, and this is the high quality electrocardiogram that we got on this patient. So why don't we ask Grace, what do you think? What does this look like to you, or what would your thoughts be, or what would your next move be in assessing this, Grace?
I am trying to look for any P waves. It looks like we have tachycardia, heart rate about 150.
Mm-hmm.
And it's kind of a wide complex, but not so impressive. Might be just the normal QRS complex. I would probably get an atrial. We're post-op, so we have atrial wires to get an atrial EKG.
Okay, that was a good choice. So one of your co-fellows who's on the line did just that. And here is that atrial electrogram.
Mm-hmm.
And I believe it's on V1.
Mm-hmm.
So what do you think about that?
So it looks like there's a P before every QRS with a regular PR interval. But I don't, and I see the P waves maybe a bit better on this tracing. Does look upright in AVF. But it does look like, so it potentially could be sinus rhythm by just looking at this. But it
So
could
let's
be.
just be clear for everyone who's here. So we're looking at this is the QRS. So anything that's in line with the QRS is a V, and then everything else is an A. So this is the atrial electrogram. So you're saying, Grace, just to restate, that that there seems to be a P wave that is in front of every QRS, or
Yes.
alternatively, a P wave that is after every QRS.
Mm-hmm.
If this P wave is going to this QRS, it's a somewhat short PR, but it could be. This is a small infant, right?
Mm-hmm.
So All right. So this rhythm actually came on suddenly. I'll give you
Okay.
that extra datum. So anything else that
is it responsive to well, is there variability or is it responsive to adenosine if you did that?
well, good question. It is not varying. And the doctors in the ICU were kind enough to rapidly pace the patient at 200 beats per minute, and then the rhythm changed to this rhythm.
Slightly slower, and QRS looks about the same. The
Right.
PR interval looks different.
Looks a little different.
So that's
So this is a reentrant arrhythmia, right? Because
right.
should not be able to terminate an automatic rhythm. So this isn't sinus, which it could have been, right? Except we know that it started suddenly. And what we theorized, so in retrospect, then, if we go back to this tracing, basically what we're saying is that there is a very long R to P interval here.
Right.
This is really, really long. So if you have a patient who has a long RP interval,
Yes.
that's reentrant, what are you thinking about in terms of the differential diagnosis in your mind? So I just call you on the phone. I'm the fellow. You're the attending. It's 1993. There's no cell phones that can send tracings. And the fellow calls you and says, Dr. Kong, I have a patient, complex heterotaxy after stage 1, who is in tachycardia at about 160 beats per minute. And the RP interval is like 300 milliseconds. So what would you be thinking about in your mind as a differential diagnosis for this? Oh, and it started suddenly. And I've pace terminated it, but it keeps restarting.
So I would think PJRT, EAT, or atypical AVNRT for like very long RP.
That's very good. So again, EAT, PJRT, or atypical AVNRT. Atypical because in typical, the RP interval would normally be short, meaning less than 70 milliseconds. So yes, those are all possibilities. Any other additional ones in this patient?
So actually for this patient, I think this is the one that Howie had sent out an email to figure out the rhythm for us. And with heterotaxy, we're thinking of a twin AV node.
Right.
And basically going down one of the AV nodes and up the other AV node is creating the reentrant circuit.
That's exactly right.
And your lecture actually touched on this, I remember as well.
Right. So, when a person has, excuse me, twin AV nodes, the theory is that there is an anterior and a posterior node, and that they are connected through something that is sometimes referred to in some of the papers on this as the Mönckeberg sling between the two nodes. And you can have reentry between them and around them, and it can be very challenging to manage. And this is a case report from just last year of this type of thing in someone with an L transposition. This has, by the way, been described in multiple types of patients who have heterotaxy. And basically what they're showing is that in tachycardia and in sinus, the QRS morphology is the same. And essentially they are theorizing here, based on an EP study in this patient, that there was a VSD patch with a superior and inferior, an anterior and posterior AV node with this Mönckeberg sling between the two, allowing for reentry. And then they show us how the intracardiac tracings recorded from each of the nodes, node 1 and node 2, and how you're going from VHA and then AHV. It's pretty complicated stuff here through the Monkeberg sling. And then typically what happens is that you ablate one of the nodes, usually the one that has less good conduction characteristics. So you can actually, usually another proof of this is to pace near each of them and to get a different QRS morphology. And that sort of cinches your diagnosis. Also, of course, recording an AH and a V in two different locations would also, of course, be useful and helpful in making this unusual diagnosis. So in our case, do you recall what we did for this patient? I'm going to actually ask David, because I think it was David who provided us with these lovely tracings.
Actually, it was somebody else, I think.
Ah, okay. Sorry, David. Or sorry, that's somebody else. But what would you do, David, since you're here? So you have this patient, you're after a Norwood. How would you treat this medically? Or would you send this patient for ablation? What would you do?
I mean, at this stage, the patient just post a complex surgery. I wouldn't ablate at the moment. I think that possibly you could use a beta blocker. Would that be a fine?
You could use a beta blocker, but so if you're in the ICU though, and the patient, let's say we're post-op day 1, we're on a ventilator, how would you administer this beta blocker?
Right, that would typically be an oral agent.
Well, there is an IV beta blocker you could use, right?
As you could use esmolol.
You could use esmolol. Okay, so that's one option, although
there's
that's
sotalol.
perfectly reasonable. You could give
Sotalol
IV
has an-
sotalol, which, by the way, we now have on formulary. Although we decided on the pharmacy committee, of which I sit, that at least in the beginning, it's going to be, it'll have to be approved each time by either me or Barry, since it's not been used at Mount Sinai yet. But yeah, IV sotalol has been described to be a very nice agent that has fairly little hemodynamic embarrassment associated with its use. What else could we use, Dave?
Amio would be another choice.
Right, you could use amiodarone, which is very effective for almost all arrhythmia. Any other agents that we might consider?
I mean, we could consider flecainide, but that's another oral agent.
Right, so you could give any of the oral agents, but probably in somebody who's so soon after surgery, who's in low cardiac output, we might be a little concerned about giving an enteral agent.
So digoxin would be another choice.
You could give digoxin, yeah, that's a possibility. You could also give procainamide, right?
Yeah.
Procainamide would be, for a lot of people, might be the first choice. Now, it's interesting. Some of you may have read there's a newer agent called ivabradine, which is an agent that can only be given anterally. Is a very good antiarrhythmic agent, particularly for jet. There's a paper that came out of India about a year ago now, showing very good control of jet with this agent. The problem is it's only available enterally. And now that said, in India, they used it that way and had very good results. But my personal attitude is I would rather an agent that in an acute situation, I'd rather have an IV agent that I can titrate and adjust. You just really don't know what the absorption is going to be in somebody who's in low cardiac output and in the postoperative period. So my preference in that case would be something IV. So in this case, we actually were very conservative. We gave the patient IV amiodarone and then transitioned to oral amiodarone. And actually, the patient has not had any tachycardia following that. So we're going to have to make a decision, though, at some point if we want to consider ablating this patient before the Fontan, at which point, of course, it'll be much more difficult to get inside the heart. The interesting thing in reading a little bit about this is it does seem that it's not uncommon that one of the nodes will stop conducting or will develop such weak conduction that this type of tachycardia becomes less common as one gets older. So it doesn't always have to be ablated. I think it can actually self-resolve with worsening of the conduction of one of the twin nodes. So I think with that, we're going to stop a little early today. Sorry again for the confusion about the room change. Just please check your email that I sent out on Friday for the room. It might be changing. I'm going to try to see if I can create a recurring event, and then we'll have the same room every week again. So hope everybody has a great day, and thanks for joining today.
Thank you.
Thank you.
Thank you.
Take care, guys. Bye-bye.